have a bulldog that twists.
Welcome back, everybody. Thank you for being here, and hopefully you enjoyed the long break. So what we're doing now, we're going to be talking a little bit more with a bunch of, I'm going to have everyone introduce themselves, but just talk about the public health response and kind of what we did to, really keep our communities and schools safe. Just for you guys that don't know me, my name is Anna. I am our Director of Public Health and Research Partnerships here at Shield, Illinois.
Hi, I'm Judy Kauerauf. I am the Communicable Disease Section Chief at the Illinois Department of Public Health.
Hi, I'm Julie Pryde. I'm the Public Health Administrator at Champaign-Urbana Public Health District, which is located in the same city, thankfully, as the University of Illinois at Urbana-Champaign.
Hi, I'm Barrie, Bode, and I am the Director of COVID-19 Facilities at Northern Illinois University.
And my name is Vidya. I'm an infectious diseases clinician and an educator at Southern Illinois University, and I also serve as the medical advisor to Sangamon County Department of Public Health. That's in Springfield, capital city.
So as you can see, we have a great panel here. The first question I'm gonna kind of have them respond to is they're just really gonna talk about what were your guys' successes during the COVID-19 pandemic?
So it took me aback when she asked me that question because I've been spending the last several months talking about what didn't go well with after actions, and I always start an after action with, after I've just got lots of things we could have done better, is we have to remember this is a pandemic. We were never going to be prepared. It was massive. So we normally in communicable disease, so my section handles data. So any infectious disease gets reported to us, we investigate it, we find outbreaks, we investigate the outbreaks, we do our thing, the outbreak ends, so that we get the food off the market, or we have people stay home, and it ends. Hep C was probably the only disease that was more chronic, and it was our highest volume at 15,000. So with COVID, we had 4 million cases that came through our surveillance system. And we patched it, we band-aided it, but it worked. Our surveillance system was able to survive with 4 million cases coming throughout the year. And so I think that's a success. Our surveillance systems, as fragile and as much in need of updating that they were able to get the data. We put data out in real time, and you epidemiologists in the room, that is something we never do. We don't do data until it's clean, it's final. You're not getting our data until it's there, but the public needed to see, they needed to know where the data were, where we were seeing cases, and so we still did our darndest to make sure it was accurate. And I cringe whenever anybody questions the validity of our death data, because that's another success is we have had death reporting since H1N1. I kind of pulled a fast one with our vital records with H1N1 because I'd wanted their data to come into our system for a long time and forced them to essentially do it during that epidemic. And so we were having the data already flow into our system. And so every death that comes in is validated from a death certificate. We follow up. So I was very confident that if we counted a death, it represented a real death. And so I think some of the infrastructure we had in place really allowed us to get that data out there. And then I'll just say one more to save for the rest. We did webinars. Some of you may have seen my face a lot throughout the pandemic, but weekly we're doing webinars. We were weekly talking to the schools. We were weekly talking to long-term care facilities. And these are entities that we had worked with, but we didn't have a relationship like we did during COVID. And so we were weekly getting on, and I was answering questions, and my favorite response was, it was true on the day that I said it, because I could say one thing one day, and a month later it would be different. Antigen testing, PCR testing, and trying to explain if it's antigen negative and PCR positive, what does that mean? And should I isolate? Do I not need to isolate? So I think those were a few of the things that I think we did well.
I think at Champaign-Urbana Public Health District, we probably were in about the best possible world for the pandemic to hit. I had almost my entire leadership team that went through the H1N1 pandemic with us. We had We had all of the materials we needed. We had a large fund balance to be able to not have to wait until any funding came in. If we needed something, we bought it. For example, the freezer, when we knew that we were going to need a super freezer for the vaccine. And we had an amazing team. We were able to hire in about 75 people to do contact tracers. And we went into the incident command system. I mean, we had support from everyone. We had worked with them on H1N1, but previously, before H1N1, we got a grant from the CDC that allowed us to work with a lot of like fire and police and government and the coroner and the hospitals and bring everybody together, help them do continuity of operation plans, really talk to them about pandemic preparedness, and spend a lot of time with that. So, I mean, I really thought we were as prepared as any place possibly could have been, and it was still, a nightmare, basically. We lost 321 people, and there was actually a time where I thought we would lose 0 people. So that was always, a gut punch. But the staff, we didn't really lose staff during the pandemic. It was just, we worked together as a team. We always have worked together as a team. But I think what made our community response so much better is that we had immediate meetings with the University of Illinois. We had meetings at the University of Illinois bringing in all of our partners in January of 2020, before most places were even talking about this. So we started then. We pulled out our pandemic response plans. We contacted our partners. We said, brush these off. You're going to need them. So we had the mayor's support, we had the university support, we had it up and down. The sheriff, when somebody wouldn't close a restaurant, we would go to court and we would win. So we had the sheriff's department, we had the state's attorney. So, I mean, what I would really like to see at some point is how a place that had as much support as we did fares against a place where the public health department had no support. And there were a lot of those places, so. I'm really grateful for how our community came together during this time.
Yeah, so as we're talking about what some of the successes were, first of all, I have no background in public health or disease mitigation. I am a cancer biologist. I was the chair of biological sciences at Northern Illinois University when the pandemic hit. Because my lab was one of the few on campuses that did a lot of qPCR testing, the administration came to me and asked if we could measure the virus. I said yes. That was a fatal flaw. And so I was tapped to head up the effort, so I still chuckle when I say I'm the head of COVID-19 facilities at NIU. But just to leverage off of what's been said so far, I think a lot of the successes we had at NIU took a page out of the translational science book, and that is to leverage existing networks that you have in place and repurpose them for a new strategy and a new direction. I was talking with with Andrew and Ron back in the spring of 2020, and we brought together the SHIELD people, Northwestern Medicine, who is our healthcare provider on the NIU campus, and our resources in NIU to cobble together the SHIELD testing program that we ultimately came up with us coordinating the infrastructure, Northwestern Medicine mediating the collections, and SHIELD providing the technology and the regional testing labs for running the samples. And the success story is that we were able to bring students back to campus. We were essentially shut down, as most places were, in the early phase of the pandemic. And we were able to bring students back to campus because of the SHIELD program in the spring of 2021, because of that. So that, to me, was the big success story.
So Springfield is much smaller than Chicago. There are some advantages to that. There are a few hospitals there, a few medical systems, but I think the biggest thing was everybody came together. The messages that were sent, in fact, on one letterhead with all the logos, which I think was a huge success. I remember I used to see patients at night. During the day was all, working on the guidelines, protocols, whatever that we needed to do. So would be doing that during the day, and I would go to see patients at night. And in one of the hospitals, the nurses came up to me and said, "This is the first time in 25 years or so we're seeing both the hospitals come together and give a unified message." And I thought that was an amazing success. And we're in fact striving to keep that going, that collaboration piece, to keep that going. Competition aside, business aside, I think this is really good for the community when people come together. So that was truly a huge success. I remember the date really clearly, 8th March 2020. I had just returned from a big fat Indian wedding of my brother. And I come back, and as soon as I came back, the public health department, the director, Gail O'Neill, called and she said, we have a patient, first patient in Springfield, admitted to the ICU. What do we do? So, we had to figure things out, and it really helped to be able to do that in collaboration. The piece that Dr. Barnes was talking about, academic medicine, patient care, hospitals, and in the community where people are sick, falling sick, or what do you do? And that in collaboration with public health, I think went really well. One other thing is messages or guidelines coming from CDC don't always apply to where you are. They will give you a broad guideline, which you actually need to morph and customize that to where you are. And again, the next piece there was information from Judy coming from IDPH. Again, is that applicable? What is applicable in Chicago is not really applicable in Springfield and Southern Illinois. So a lot of the counties that SIU had its presence in, we had to take into account a lot of things and then come up with guidelines locally as well. A lot of times we, in fact, followed pretty much the same thing, but there was a process, there was a method to follow and say, yes, we agree with what CDC says, the same thing applies here, and what IDP had said, and the same thing applies here. So I think that process, figuring it out, and being successful in that, I really value that, and we are making a big effort to continue that whole process again.
Thank you guys very much. I think the next thing we just really want to talk about a little bit more is, COVID-19. It would be great if there was never going to be another pandemic. As we know, that's probably not the case. So really, if you guys can share, what type of lessons did you learn during the COVID-19 pandemic that will help you, better respond to your communities and schools in a future pandemic? Should we start with someone else? You guys, yeah.
Okay. Well, we learned a lot of lessons, definitely. And every year I work in public health, you learn lessons and you put those down and you hope to be able to use that for the next pandemic. Of course, now I'm extra concerned about documenting things because I don't plan to be there for the next one. I'm just saying, COVID was my third, so. So that's the big thing. But we've done a lot of, after action, and we've done an after action report, and we're continue to talk with our partners and everything. But I think that our university partnerships were just absolutely wonderful. We already had a good relationship with IDPH and have for a very, very long time. So having the new people from IDPH on board was really helpful, especially when I was working with leaders when we were talking about closures or when we were talking about doing something that was going to get a lot of political pushback. There was nothing like having the U of I modelers on those calls. that was fabulous. And then they would, put up a slide like Dr. Smith put up, and I'd be like, yeah. No idea what it said, but I knew. But I trusted them to know, so that's important because it gave, and also one really interesting thing that happened is that we started working with the business community, and I know a lot of public health departments do that, but we really have never had a really good relationship with the business community. And I think about having the modelers on the call and the university, the chancellor's staff or the chancellor sometimes, and different people, and the mayors, and we're talking about how are we going to prevent, when the students come back, how are we going to prevent, just a massive mess? And, it was great to have them on there because I can think of one time where the businesses were actually on the call, the bar owners, that's a particular concern on campus, obviously, and to have them on the call and then them listen to everyone and then they voluntarily closed the bars when the students came back for a while. That was amazing to me. And then they did that because they could see that it was going to be in their benefit in the long run, not because anything we were going to do, but because the students would, be able to stay in school. Then they could be there later, throwing up in their bathrooms. But so that was one.
Well, since we're talking about lessons learned, I think a lot of existing trends prior to the pandemic came to the surface. And among these are things like the politicization of science and things of this nature. And we live in a very polarized society right now, and it's really hard to get messages across that translate to public health outcomes. And so I think one of the things that at least from in my field, that we can do better is to communicate science to different communities in a way that will resonate with them and make it clear that science is a process, and if we don't know something, for example, about SARS-CoV-2 when it first emerged, that doesn't mean that we're hiding something or that that answers are immediately available about these things. I think just educating the public in general that the medical community, the public health community. We heard this in the opening address about public health workers being bullied, and we need to make it clear, I think, that this is an apolitical enterprise. This is information. It's science-based. Science is inherently reliant upon gathering data and information that we may or may not have yet. And so it doesn't mean that things are being hidden or massaged. It means we just need more time. And I know that's not satisfying to a lot of people, but I think in between now and hopefully the next pandemic, which none of us will be involved in, we can work on some of these issues that have come to the surface so that we're better prepared next time that we do face these challenges. And so that's a lesson that I gleaned during the pandemic.
I'm going to piggyback off of that. I think that was the biggest lesson for me too. I'm going to quote Dr. Ashish Jha, who says, same thing, science is a process, not a destination. And what applies today is not going to be applicable tomorrow. And that was, I think, the hardest to communicate, to break it down, to simplify things and explain. Science was actually unfolding. What we read in journals was actually unfolding on a global stage. And, to me, that is fascinating, but to a lot of people, it isn't. So I think to explain and to be able to support with evidence what we say, substantiate what we say with evidence. Communication, I think it's really important. When we communicate something, we have to say why. I think that's where we made a big mistake. When we communicated, we didn't always follow that up or substantiate it with a why. We may not have the answer for the why, but why was that decision made with the information we have would be very, very helpful. So definitely that's something that was fascinating for me. Secondly, COVID shined the light on inequities that we have in our community, and we learned a lot in terms of what we can do, how we can identify those, and just make healthcare equitable. So definitely those two, we have a long way to go and improve upon.
Yeah, I would agree, and just kind of rounding out all the successes, we can't really have a public health symposium without saying vaccines were a huge success. I just think, I remember having a conversation with Ngazi, our director, about that, and I was so excited. I thought, here's vaccine, the pandemic's over. Just a few months, let's get everybody vaccinated and we will be done with this. And she just cut me to the chase and she said, have you seen the data on how many people are going to be vaccinated? And I was like, no. That's your time. It was very deflating at the same time. But I think we were successful in getting those at highest risk. The data on what we did in nursing homes, what we did in jails, the level of vaccination. I think we've talked a lot about knowing your audience, partnering, and the vaccine uptake we had in state prisons was at 95% because the director at that time was able to be successful in communicating that to the offenders that were in the system. And sadly, the ones that weren't getting vaccinated were the staff. I don't know that we dealt with that well, because I kept trying to communicate these staff are bringing it in to both any congregate care facility. Those people aren't leaving, so it's getting brought in, and we have to somehow convey to, and that's, nobody was going anywhere, right, during that time. So those staff that were going into these nursing homes, or in especially the nursing homes where we had such a vulnerable population, had to be responsible for their behavior when they weren't at work. And there were some, that wasn't happening. We had one huge outbreak where we knew there was a Halloween party that happened that started the outbreak due to transmission during that event. And so, I don't know that we communicated a responsibility enough to those staff, and I don't know how better to do that, but it's one thing that...
Mandates.
Mandates, yeah. That is one way we had to do it, right? The other thing I think that we as a society hopefully have learned to do better is to stay home if you're sick. We're dealing with group A strep right now in schools and seeing some pretty severe cases. And it was funny, you had to remind people what we were seeing with group A strep is that they would have a sore throat, get a test, negative for COVID, so they're going to school. And everybody was okay with that. And we had to be communicating again, no, you're infectious. You can be infectious with a fever, and you need to stay home. So the other thing that I think was a big success was our collaborations, and I can speak probably mostly about that with our school work group. And it was interesting that during this time, COVID was the only thing on the news, really. And so you were constantly, in my position, I was just fed with all kinds of information and trying to think of different ways we could do things with mitigation, especially with masking, testing, and vaccine. How can we communicate better on how to convince people to wear a mask, to convince people to test if they're symptomatic, and to get vaccinated. And we had a school work group from the very beginning, and we met. I always called it my hour of power because I could get Vidya on there, a physician from Springfield, infectious disease pediatricians from Chicago, from U of I, U of C, on the phone, local health departments like Judy, to help try to solve what's going on. And then also had partners from State Board of Ed there that were, at times I felt like they just wanted COVID over, and they didn't even want, we had some pretty aggressive meetings that ended in tears sometimes. There was some shouting, but they were advocating for their community. They needed those kids in the school. They needed those kids learning, and they were advocating for the needs of their children on the educational side as much as I was advocating on the public health side. And we had to come together. We had to sacrifice a little bit of what we needed. They had to sacrifice a little bit of what they needed to make this work. And that's where Test to Stay was born out of that. We just kids need to get back to school, and quarantining for 14 days was just not okay anymore, and it didn't make sense. And so Test to Stay was just one of the things that was born out of that school work group, was really solidified in their recommendations. So I think that was probably one of our other successes.
Perfect. As we know, the goal here really is to bring academia and public health together in terms of that. So really would like you guys to share, what do you wish you had more information on or more and what type of research would you like to see done to help you better prepared in the future?
I can start. I think definitely surveillance and more data collection systems. Definitely want to see that more. As we get new information, for instance, now post-COVID, there's patients we take care of. There's a lot of data that we're not able to capture. So, we have students, we have learners at the fellow level. We try to put everything together, but resources there would definitely be more helpful. I also see a disconnect between information that's so readily available and in abundance from the public health departments not actually translate or be conveyed in a timely fashion to people taking care of the communities, even in the academic settings, that information, if it's conveyed in a timely fashion and in the same abundance as it's available, I think it would definitely lead to a lot of better data and just better overall in the community. So yeah, I think those are some of the things.
So in terms of, there were a lot of questions in there, and so from our perspective, one of the things you're going to hear about tomorrow is wastewater surveillance testing, which is what we're currently doing, and we're still learning about its utility, its application, how it might be leveraged in connection with public health departments to monitor community level unbiased testing, and how we might be able to bring those two entities together, public health and wastewater surveillance testing, to respond to whatever health challenges there are out there, because the principles involved are a bit transcendent. One of the things, and Anna, you had asked, what do you wish we had more resources for? I think we heard it this morning. Number one is the public health departments have been kind of devastated around the state, loss of personnel, things like this. We've worked closely at NIU with the DeKalb County Public Health Department, but they've lost so many personnel over there, and it's hard to forge new programs when they're struggling to keep up with their day job. And so that's what I wish we had more of, is just general public support and more resources for public health departments, so that we could be proactive instead of reactive to these challenges when they do emerge. And that's what I would like to see. The science is going to be there. We're doing some of that now. We can talk about it tomorrow, but wastewater surveillance testing, I think, holds a lot of promise. It has predictive value. And how do you leverage that predictive value in kind of operationalizing it at the public health level? And I think these are some of the challenges and resourcing issues that I see from my perspective.
there are so many things that I think would be wonderful to have. We have a lot of relationships with the U of I and other colleges as well. But what I think is best about our partnerships are that the researchers come over there. We have no idea what they're talking about most of the time. But if they, have an idea of something that they're wanting to test, then we can look at our staff and look at our agency, our clientele, what we do, and see if it can fit in there. And I think that the more we do that all the time, the more they'll understand what public health is, and probably not so much the students, but like Dr. Smith and Dr. Tab and the different people that we deal with from the U of I all the time. They know they kind of get a good idea of what our health department is like and what we have the capability of doing, and can they put staff in there, et cetera. And then they'll know. They'll hear what we're talking about. One of the things that I'm very excited about, the wastewater surveillance, way, way, way excited about that. I would like to see, anytime a local public health department or the state public health department can get even a couple of days jump on something, it makes a huge difference. So, if we knew that there was measles, for example, we spring into action, we know what to do about that. So any of the vaccine preventables I would like to see screening for. God help us if polio comes around. But, that's, to get even a couple of days jump makes a big deal. I was talking to some communications researchers at the U of I the other day, and we were talking about what they're interested in, and then I said, well, here's what we would be interested in. And they're going to do something that the best I can describe to public health people is it's kind of like syndromic surveillance for misinformation or disinformation. And, I told them, if we can get a head start on that, we don't have time to monitor all this stuff, and they have, machine learning that does that somehow. And so anytime we can get a heads up that, hey, this is the rumor out there, then we can get a jump on it to try to do something with that. And that works with, basically anything. But when I started 28 years ago, when we had any things with the U of I, it was very much come in, do a study, they'd do whatever they did with it, publish the paper, we'd never hear from them again. That is no longer the case and hasn't been for, the last probably 15, 20 years. We're more partners, and we need to see that all over the place, because public health is one of those places that I think is often just kind of overlooked by researchers, just because we're always just kind of doing our job and there's not a lot of interaction, but I think there's a lot of promise there. I love the idea, at the very beginning of the pandemic, what we wanted more than anything was an antibody test, because of course we assumed sterilizing immunity from infection, which of course was not the case, but we wanted that so badly, because that would have been able, then we could have had our spare short resources focused in a different direction. So anything like that. But the good thing from the very beginning is that we were immediately communicating back and forth. So anything, no matter how weird of an idea we would throw out there, they would look at it and take it seriously, and at least go off maybe in a different direction, or at least they had the decency not to giggle until they were out of the room. But they allowed that open space where we could just communicate, communicate back and forth all the time, and that is very, very helpful.
Yeah, and I would like to see as much analysis as we can document about what worked. I think at the Rural Health Conference in October, I did a session on isolation and quarantine, October of 2019, thinking, I'm going to talk about this. It really isn't very relevant. I had to research a little bit, because we isolate people for measles and TB, but we never quarantined, really, ever. We restrict people from work if they had an enteric disease and some other things, but we never really used quarantine. And so I remember using some of the examples from 1918 and some of the same things Dr. Barnes did from history that showed it worked. And we need to do that for this. I would really like to see at what point quarantine stopped being effective, because we held on way too long. And I kept saying we've got to find a different way because it's okay for people that can work from home, but what about the people that don't get paid? And those are the ones that were most marginalized. Is they don't get paid if they don't work. And so we can't ask them to stay home. We have to find a better way to do that. So we have to understand at what point quarantine stopped working and not do that again. CDC was very slow to make any changes on that. That's why that's one of the areas where we just said we have to do something different and find a different way to keep people, to not have to quarantine unless we absolutely need to. The difference between rural and urban communities and how we have to deal differently. I think it was actually mentioned at this conference, and it really resonated with me, is we like to show Democrat, Republican, red state, blue state, that those are differences. But is that true, or is it maybe more rural populations versus urban populations? How do rural people, and my dad in particular, who I'm most worried about, and he was in the hospital one time, and a nurse talked him out of getting a flu shot just this year, and in a very rural area, and she got him on fear, because he's not going to read a medical journal. He's not going to be able to consume that. Someone just talked to him on his level. She was a farmer. He's a farmer. He trusted her more than his own daughter, and so he did get a flu shot as soon as he got out, let me tell you, and that nurse is no longer working at that hospital. And so that, I think we really need to understand, and I also kept saying, where are the behavioral scientists to help us out here? We don't understand behavior. We're failing because we don't understand what's going to make somebody do something, and we have to get better at not staying too science-based, that we think, okay, mask work, they put a mask on, and that's our message. We know they work, and what we found is people that were more educated in that they could read the scientific journals and understand it, and then make a personal health decision, used them. But people that we're not able to consume the research and make decisions based on that, but we're basing it on what someone said on a particular television station or what they heard from a neighbor. So we've got to learn to understand that population better. And if anybody can figure out how you can surge up. we really never were successful in getting more staff. And I think if we could figure out how to make the Public Health University Partnership work without an IRB and all the paperwork and the DUAs, if there is an agreement that we can have, Becky just knows. Every time she knows I'm the worst, but we're in the middle of day-to-day stuff to get all the paperwork done, to get stuff, data to you. We want you to I always say, we want to extend our data with your research. And so I have all the surveillance data. Please help me use it more. Like right now we're trying to do a case control study on group A strep with the invasive cases and understand why. But we really have very few resources in that. So there has to be a way to do this easier. I know other states do it better.
I have to hop on that real quick because I love that, what Judy said. And one of the things is there were counties where there were a lot of support, like my county. I was just super lucky to be in that county. So I think even if you just look at Illinois, you can look, because you can't really compare states, they're too big. You have to be able to look at what was happening in this county. And you had sheriffs and state's attorneys and mayors saying, we're not doing any of this. So that's an easy county to compare to one that stuck with it the whole entire time. So I would love to see that type of analysis. I would also, and I have to go back to this because of the nurse, but we have got to get a legislative or rulemaking or whatever kind of thing that says if you work with vulnerable populations, you must be vaccinated. For God's sake, that is the very minimal thing that we can do. People are in there, they're not leaving the jail, they're not leaving the prison, they're not leaving their beds at the long-term care facility. If you're going to interact with these people in a job, they need to be vaccinated against every vaccine preventable disease, because I shudder to think how many deaths were caused by that.
Perfect. Thank you, guys. knew this panel would not finish early. But yeah, but we do have a few minutes for any questions. If anybody has specific questions, we don't have time for everybody to answer a specific question, but if anyone has any questions that they would like to ask. Anyone? I know that light, I think probably is.
Everybody's shadowing.
Hi there, John Emerson. I am wondering if you can comment on public-private partnerships and how they can help or hinder the partnership that you're discussing about public health and academia. And in particular, how one might guide them towards supporting issues of equity for underserved communities.
Well, I'll take a stab, because God knows, give me a microphone, I'm going to yammer. But, so the equity thing is really important, and we didn't really talk about that a lot up here, but, you know, public health has known for a long time about these inequities, and we have been talking about, you know, what we can do to help it. But the fact is, you know, COVID made it visible for everyone. So unless you literally had your head stuck in the aisle of, you know, ivermectin at the Farm and Fleet store, you probably know that there were a lot of inequities, and we need to, you know, address that. And public health can only do so much. It's going to be businesses dealing with their institutional racism and the structural racism and just getting people to, first of all, understand what it is, and then look for ways to fix it. But that absolutely has to be a public-private partnership to get those things done. So that the hospitals, the clinics, everybody needs to not only talk about that and not only look at their own systems, but they need to make that public to let everyone know this is what we're doing and this is why. So I think that there is a lot of opportunity there for that. And I'm hopeful. I mean, all the way during COVID, when I was, you know, my head against the wall, I kept thinking, you know, when we come out of this, people are going to understand this, and we're going to be able to make a big difference in inequities, and we're going to be able to make a big difference in that. Now, will that happen? I don't know, but it does seem like there's some momentum, and I've been happy to see, at least locally, how a lot of our ARA funds were spent, and so it seems like we may be getting, you know, movement in that situation, but it has got to be more than just government. I think certainly that's not going to work.
So, I just want to.
Well, I think equity is something Illinois did so well from every angle, and we learned from it. And when monkeypox hit, or mpox, I thought we are not going to make the mistakes we made with COVID. We have got to do things better, and it went so well with us right from the beginning, thinking about equity, thinking about messaging, thinking about trusted messengers, crafting our message, our vaccine uptake messages to what the community wanted to hear, the priority populations wanted to hear. And we went, our epi curve, if you want to look at it, it just tanked within 2 months. And we had a call with CDC yesterday, and they were trying to equate it to something that they did in August. And we were saying, we were already 2 months into it. We did that. We got the vaccine out there to the right people. People made behavior changes because they cared. And it was a huge success story. But it had a super strong equity approach in the front. And then I was thinking about, during that, of getting vaccine out, and we were scrambling to try with scarce vaccine to get it out, and thinking about partnerships with pharmacies. And pharmacies were a huge partner during COVID in getting vaccine out, as were long-term care facilities, really every business. It went from just every step along the way. We would get one thing solved, and then there would be another community impacted, and then there would be another community impacted. So we went from long-term care facilities to homeless shelters, and then workplaces, and most of we could spend a day on the workplaces, and especially the food processing centers, and all of the issues there with those essential services that had to continue. So, but I think it's something we need to explore more. It's very hard to get partnerships in a procurement world in state government, but for those things that don't need money, we're all about it. Vidya, do you want to add?
Yeah, I just wanted to add that, you know, it's very important for all communities, all groups to have a seat on the table. And I think Illinois did a great job. SIU, which is in the southern part of the state, we got called a lot more. So I think just having a seat on the table is very, very important for all communities, and especially marginalized communities. And then with respect to public-private partnerships, I think it's really important to keep the greater good in mind. If the missions align, I think we definitely will be able to do much better.
Perfect. Well, thank you guys all for sharing your information with us today, and we are going to wrap this up and get on with the next presentation.